Hi, this is Dr. Mario Del Cid from the Retina Group of Florida, and in this video we're going to go over the basics of the eye exam. We'll discuss issues related to checking vision, pressure, pupils, confrontation visual fields, extraocular motility. We'll look at doing the external eye exam as well as a slit lamp exam, and finally the fundus. So let's dive right into vision. This is probably one of the most critical components of checking, of doing an eye exam, because vision is critical in terms of us identifying who is doing well, responding to treatments, what the condition may be, and so on. So it's important to take your time with this portion of the eye exam. Usually we like to check vision with best corrected spectacle correction. That is, you want them to use their eyeglasses or their contact lenses during the vision portion of their test only. All right. After that, you can take off their spectacles. Maybe for visual field testing, it'd be important to have their spectacles still on, but otherwise, it's usually preferable to take them off for the rest of the exam. When it comes to best corrected spectacle vision, it's important to know how to document the vision. And so when you see CC, it just means with correction. When you see the SC, that's without correction. It's helpful to check both near and distance. Of course, near vision, you check it's done on a different scale. The distance vision is documented as Snellen vision. The near vision is used. You utilize your handheld J chart. It's important to check one eye at a time. Oftentimes, you'll find a patient can compensate with the fellow eye, and one eye may be having lots of vision problems, and they may not be able to pick up on it because the fellow eye is compensating. So be sure you use the occluder. It is important to check pinhole vision. Pinhole, what it does is it sort of gives us an idea what the vision would be if they had better spectacle correction, or if the media was not obstructing the vision towards as it gets towards the retina. So it gives us an idea as to what retinal function is, and so pinhole vision is actually quite important. And the way you document that, you would say, the vision is 20/40, but with pinhole, that is that pH, the vision improves to 20/20. So this is obviously a patient that actually has very good vision and maybe just needs a little tune-up on their eyeglasses. In terms of documentation, the Snellen chart goes from 2020 to 2400. Usually there's some that may have a slightly different scale, but this is the more typical scale we see on our Snellen charts. And so you want to clearly document what their vision is on the Snellen chart. 20/30 plus means they were able to see not only the 20/30 line completely, but they were able to see one more letter on the 20/25 chart. 20/25 minus means they were unable to see all the letters on the 20/25 chart. In fact, they missed one letter on the 20/25 chart. For all intents and purposes, 20/30 plus is equivalent to 20/25 minus. All right, it's almost the same thing. And so, I'll sometimes have patients come in and say, well, my vision was 20/25 last time, and now it's 20/30. It's gotten worse. And when you really look at the semantics here, it's roughly equivalent vision. If they're unable to see any of the letters on the eye chart, then their vision is count fingers. And so what you want to do is you want to put your fingers in front of the patient's face, and then if they can see it roughly a foot away from their face, then you want to get further and further away from them, and then you want to document at what distance they were no longer able to see your fingers. And so count fingers at 1 foot or 2 feet and so on. If they're unable to see fingers, then the vision is hand motion. That is, you're waving your hand in front of their eye. Remember, the fellow eye is occluded. And then you want to document how far you had to go before they were unable to see your hand moving. Finally, if they're unable to see hand motion, then you document this as light perception. Don't worry too much about projection. Projection just means they're able to see whether or not you're shining the light and it's moving left to right or up or down. That's not quite as critical. And finally, if they're unable to see any light, you would document this as no light perception. Now, this is really important. If you think the patient has no light perception, you want to be sure of this, because as it turns out, for us, that makes a huge difference in terms of how we would treat the patient. And so if you think the patient is truly no light perception, you want to make sure that the fellow eye is completely occluded. Usually what I'll do is I'll put a tissue and kind of bunch it up and have the patient close their fellow eye, and then I'll put that tissue over the eye. I'll find the brightest light I can find in the room. So a little pen light doesn't do the trick. You need to find the brightest light you can find and really confirm that there indeed no light perception. Next is intraocular pressure. The most precise way to check pressure is really with your applanator, but there's other ways to check the pressure. The tono pen is available in most of our offices. It's easy to use. I don't want to say it's the least precise, but it's less precise, let's say, than applanation, at least when it's done well. If you're not doing applanation well, then honestly I'd rather use a tono pen. And there's other situations where tono pen is better utilized if the patient's unable to sit up at the slit lamp, if they're not very cooperative, if you're just having a hard time with the applanator, then certainly having the tono pen available is just fine. Some of our offices also have a Perkins tonometer, which is also a good way to check the pressure. None of our offices have that puff test that's done at some other eye doctors' offices. In terms of applanation, it's real important to know how to line up those Myers. So the top pictures there show the right and wrong way to line up these Myers. So the Myers should not be aligned completely apart. They should overlap. And what you want is you want that inner ring, that inner aspect of the Myers to line up, as you see here on this diagram. And then in an actual photo of the eye, you see this is really nice. This is a normal thickness to the Myers. You see the Myers aren't too thick, they're not too thin, and the inner circles are being matched. That would be a very precise measurement in terms of eye pressure. A couple of pitfalls here. Sometimes if the eye is too wet or you put too much fluorescein on the eye, then when you check the pressure, the Myers are going to be too thick. So this is a patient you need to kind of dab their eye a little bit, get rid of some of the fluid on the eye so that you can better check the pressure. If you didn't put enough fluorescein on the eye, or their eye is just very dry, then the Myers will be too thin, and so it's very difficult to align them. So this picture here shows very a good thickness to the Myers. Finally, when you're checking the pressure, you want to be sure that you don't put any pressure on the globe. So some patients will squeeze their eye. You need to kind of prop their eyelid open a little bit. Be sure when you do that you're pushing on the bony orbit that surrounds the eye and that you're not putting too much pressure on the eye. If you do that, then you'll get a falsely elevated pressure. A pupil exam, these cards that we have in the rooms have a little measure for you to compare what pupil size should be, and so I urge you to, when you check pupils, especially when you're starting out, to compare it to this measure so you can get a good sense as to what normal pupil size is. If you were to do a very detailed pupil exam, you would actually want to check it in both dark and light conditions. Truthfully, in our offices, checking it in dark is just fine. You want to measure the size, the reaction, whether it's reacting quickly or slowly, briskly, or sluggish. Reaction can be affected by a lot of different things, including prior surgery, trauma, if the iris is captured by something like an intraocular lens. You want to check one eye at a time. A consensual light reflex means you shine the light in one eye, you see the pupil constrict, and then you actually see the pupil constrict also in the fellow eye. That's actually normal. And lastly, you want to be sure you do the swinging flashlight test. This is a very important test. It's called the Marcus Gunn pupil, or really checking for a Marcus Gunn pupil or an afferent pupillary defect. So this is a really important test. It is a very good predictor of visual prognosis, and I think it's so important that if you think there's an abnormal swinging flashlight test, you should definitely make the doctor aware. So, in a normal eye, this is a normal eye is the left picture, an afferent defect will be on the right side of the picture. So, let's focus on these normal exam first. In ambient light, really in our rooms, the rooms are relatively dark, you see the pupils quite large. This is, maybe like a 5mm pupil. And you see they're the same size on both eyes. You shine the light here, the light's being shined on the right pupil, and you see it constricts, and you also see the left pupil constrict. Okay, so that's a consensual light response. And then when you quickly swing the light to the fellow left pupil, you see the pupil remains small. All right, this is a normal response. You may sometimes see the pupil kind of open up a little bit, and then it'll constrict again. So some people call that hippus. It's just a reaction of new light being shined on that fellow eye. But in general, what you should see is the pupils remain small. All right, let's look at the right side of the picture. This is going to be a left APD. So what you see in ambient light, actually both pupils are a little larger than you should expect. This is maybe closer to a 7 or maybe even an 8mm pupil. When you shine the light on the right eye, this is a normal eye, pupil gets small. And look at the left pupil, it also gets small. So there's a normal consensual light response on the left side. The pupil got small on the right side. This is a normal test. Now, when you shine the light here and you swing it over to the left side, what happens to the pupil? It's actually large. That's not normal. Remember, it should be small, instead it's large. Sometimes you'll even see the pupil expand. It gets larger and larger and larger when the light is being shined on it. That's not normal. That is a left afferent pupillary defect. Confrontation visual fields. The best way to check it, you see, there's you should be about about arm's length apart from the patient. Okay, you want to close. You want to have their one of their eyes occluded, and as you're checking it, you want to occlude your opposite eye. Okay, to them. So in other words, you want to be using, if you're checking their left visual field, left eye visual field, you should be occluding your left eye and using your right eye to assess their visual field. All right, and that's of course assuming that you have a normal visual field. And I like to do what's called a 3-step visual field. Again, one eye at a time. The first thing I have them do is look at my face, and I say, hey, can you see all aspects of my face? Is any part of my face blurry or obstructed? So that's kind of looking more at the central vision. Next, I'll check each quadrant individually. So I'll put either 1, 2, or 5 fingers. It's a little difficult to discern 3 or 4 fingers. So I use 1, 2, or 5 fingers in each quadrant. And again, I'm using my visual field to assess their ability to see in each of these quadrants. The last thing is I put both hands in the top quadrant and both hands in the bottom quadrants. Okay, so at this point I'm putting 5 fingers up in each of the 2 top quadrants and 5 fingers up in each of the bottom quadrants. And I just want to make sure they can see both of my hands. Any irregularity here is documented, as you see here on that as an atypical portion of the visual field. Of course, in our electronic record, you simply just write down where the visual field defect was. And of course, if there's any issue, sometimes that requires further testing with a automated visual field test. Extraocular motility, here we're just checking eye movements. Ductions means you're checking one eye movement one eye at a time. Versions means you're kind of checking how both eyes move together. That's not quite as critical as knowing that you want to follow an H pattern. Okay. And the reason for that is it isolates each muscle in each eye individually. We'll go through that in just a second. You want to be on the lookout for tropias, that is sort of a paralysis of a particular muscle or maybe a nerve. And your H pattern here, what you want to do is you want to go start in the middle and then move your finger and have them follow your finger to each side, and then again up and down in an H pattern. And the reason is as these muscles insert into the eye, they don't insert in a straight fashion. They're actually a little bit obliquely inserted into the eye, and so when you do the H pattern, you're actually isolating individual rectus muscles, and this can sometimes give us more information in terms of whether a rectus muscle is paralyzed or whether a nerve is being affected. Some basic motility disorders. Here the top picture is showing an eye, a right eye that's deviated inwards. This is a sixth nerve palsy. This is called an esotropia. Eso because the eye is deviated inwards. Exotropia, exo is outward. So this is a left exotropia, maybe a sign of a third nerve palsy. Any tropia can be a sign of possibly poor vision due to some sensory deprivation, maybe long-standing poor vision, and any tropia can be associated with prior strabismus surgery. So if you see a tropia, worth asking some of these questions. External exam. Here you're looking externally. You're just kind of looking at how things look, sort of a bird's eye view. Here's a picture of a ptosis, that is a droopy eyelid. See, the left eyelid looks pretty normal, but that right eyelid is definitely droopy. That's ptosis. That's not to be confused with dermatochalasis. Dermatochalasis is actually excess skin. You see, the eyelid itself isn't droopy. There's just excess skin on the upper eyelids. You may also be able to observe lid lesions such as nevi or freckles, ecchymosis, which is bruising, edema, swelling, which may be due to trauma or infection. After you do your external exam, you want to go ahead and start working on the slit lamp. And I try to do this in a fairly organized fashion. I'll first look at the lids, the lashes, the lacrimal gland, then I'll concentrate on the conjunctiva and sclera, the cornea, then the anterior chamber, and then I'll finally focus on the iris and the lens. So we'll go through each of these in steps. So lids, lashes, lacrimal. This is almost like an extension of the external exam, and we're looking for things like blepharitis. Here, you see this sort of crusting on the base of the lashes. You're looking for chalasia. This is a swelling of the meibomian glands within the eyelid. A stye. You may be able to see a stye, which is sort of a chalazion right on the lid margin. You may be able to see plugs, that is plugs on the lacrimal system, punctal plugs, eyelid malpositions. Entropion is a turning in of the eyelid, and ectropion is turning out of the eyelid, and you may be able to see some other issues. Next, we would move to the conjunctiva. One can see pingueculi, which is just a process of elastosis or fibrosis on the conjunctiva overlying the white of the eye. When this progresses, it can lead to a pterygium, where this process starts to encroach into the cornea. You may be able to identify conjunctivitis, which is a reddening of the conjunctiva overlying the white of the eye. You can get edematous. It can be viral, but it can also be due to other reasons. Nevi or freckles. We see this quite often in our patients that get injections or have had surgery, which is a subconjunctival hemorrhage. It's completely benign. And in a patient with inflammation, one may see scleritis, which is a inflammation of the sclera. Next, we move on to the cornea. Some common findings: an abrasion here. This is a scratch when we put fluorescein dye and shine the blue light, we see that area light up. We may see that in a patient that's had surgery and maybe had an injection. Scars is a patient that has a sort of a central scar, maybe due to prior trauma or injury. Foreign body, this is a metallic foreign body. You see it's been sitting there for a while. It's gotten rusty. And so that's a metallic foreign body. You may be able to see some guttae if you're really good. This is on the inner aspect of the cornea. You see these little almost particulate matter, which is really isn't particles. It's something called guttae, and maybe the patient's had prior surgery, so you might be able to see a LASIK flap. Anterior chamber, what you're looking for is it should be nice and clear. Top picture is a patient that's got inflammation in the eye. Maybe they've had surgery, maybe they have uveitis, so you're seeing some cells and flare. This is what you don't want to see, which is white blood cells accumulating in the anterior chamber, and then they settle and sort of layer. This is a hypopyon. Anterior chamber depth is very critical. We talk about this a lot because you do not want to put dilating drops in someone that's got a shallow anterior chamber. It can induce an attack of something called angle closure glaucoma, which can be difficult to manage and potentially can be a blinding condition. So there's various different ways to gauge the depth of the anterior chamber. The first is the pen light test. Okay, so what you'll do is you'll shine a light from the side of the on the side of the patient's eye, and what you'll see is the light should cut across the anterior chamber. If the anterior chamber is deep, you shouldn't see any shadowing at all, and that's because you have a nice deep chamber. In a case of a shallow anterior chamber, you'll see some shadowing on the opposite side where you're shining the pen light. Again, here, when you have a nice deep chamber, there's no shadowing because the iris isn't bowed forward. So you just see a nice bright anterior chamber. Again, when there's shallowing, when the light hits that iris, you see shadowing on the opposite side, and that's due to a shallow anterior chamber. Now, a more precise way to do this is called the von Herrich's technique. What you're supposed to do is you shine the light at about a 60-degree angle on the slit lamp. Okay, you want to get a nice thin slit beam. You put it at about 60 degrees from the 60 degrees angle from the limbus. And what you should see is the thickness of the anterior chamber should be greater than 1/3 thickness of the cornea. So what does that mean? Well, here we're shining the light at a 30-degree angle, and you see how much space there is between the endothelium, that is the inner lining of the cornea, and the iris. There's a big, thick space. You see how the cornea itself looks very thin in comparison to that anterior chamber. So this is a nice, deep anterior chamber. You see on the other side, though, you see again, we're shining the light at a 60-degree angle. You can see how thick the cornea is, and you see the space between the inner lining of the cornea and the iris is minuscule. It is absolutely minuscule. It's certainly less than 1/3 the thickness of the cornea. So this is a patient that's got a very thin anterior chamber, very shallow. If you think there's a shallow chamber, then before you put any dilating drops, you should tell the doctor, and the doctor may perform gonioscopy to confirm that there is indeed a shallow anterior chamber, and if that's the case, then the patient needs usually peripheral iridotomy or some other type of treatment before we put any dilating drops in the eye. Other things you may see when you look at the iris, you can see nevi or nodules. These are freckles, or sometimes you see nodules in patients that have some underlying conditions. You may see a hole in the iris. This is a peripheral iridotomy. This is what you want to see in an eye that has a history of shallow angle, of a shallow chamber, because this hole here will help to deepen the chamber. Here you see some synechiae, that is some adhesion between the iris and the lens, and here you see a irregular pupil. Probably this patient's had prior surgery and had some iris trauma there. You look at the lens, you may see a cataract. This is a pretty obvious cataract here. This is a white, mature cataract. Pseudophakia means the patient has a lens in the eye. This is a picture of an anterior chamber lens. This lens is sitting in front of the iris. You may see an opacification. This is a posterior chamber lens, but it's gotten cloudy, and so this patient's got poor vision due to an opacity there. This patient ends up getting laser, a posterior capsulotomy, and now has a nice clear lens. You may even see the lens capturing the iris. This is a patient you shouldn't dilate. Have the doctor take a look at this first. And finally, we move on to the vitreous and retina. We would dilate the eye, and that's where your doctor takes over. So, in closing, it's important to be thorough. Again, when in doubt, be sure to ask. Ask a lot of questions as you're learning how to do the eye exam. A lot of this stuff may be new to you, and thankfully you have a lot of experienced people around you that can show you what's normal and what's not normal. And it's also important not to reveal too much. If you find one of these abnormalities, try not to reveal too much to the patient. Rather, let the doctor explain some of these findings. Thank you so much. Hope you enjoyed the video.